This section, I want us to consider the concept of automaticity, and then I'm also going to be introducing some additional vocabulary as well. So the general idea, the generation of pacemaking stimuli, automaticity, again, auto meaning self-generating, of course. So you have action potentials from the SA node, and they'll start a sequence for both the atria and the ventricles to contract in a well-timed, coordinated fashion, optimized for the pumping of blood. What do I mean by that? What I mean is that the blood will flow into the atria, and of course we have the atria here. Blood will flow into the atria from the non-lung part of the body and then the lung part of the body. And of course, as we said earlier, most of it will just flow directly into the ventricles. But when we have an atrial contraction that just pushes that additional amount of blood into the ventricles, you wouldn't want the ventricles at the same time to be contracting. That would be self-defeating. So you want the atria to contract first, and then you want the ventricles to contract. So timing is everything. So when you have a action potential that is being generated from the SA node, I'm wanting that action potential to go through the cardiomyocytes in the atria for contraction, but I'm not wanting this signal to go so fast that it would go to the AV node and then to the ventricles, causing the ventricles to contract at a time that is not in sync with the atria. I want the atria to contract, then I want the ventricles to contract. So part of the job of the conducting system is to make sure that that timing is optimum for pumping of blood. So again, it has to be well coordinated. So there are other areas of the heart that can potentially have automaticity qualities as well. And as we may have mentioned, that you do have latent pacemakers throughout the heart, and the dominant pacemaker is going to be the one that is pacing the fastest and is again going to suppress, in a sense, the other pacemaking cells. But I want to get into this and just kind of talk about how all of this works together. So again, these areas of the heart we would call automaticity foci. So automaticity foci is just basically an area of the heart that has the ability to generate its own action potential. So normally, the only automaticity foci is going to be your SA node. But the others are out there, they're just being suppressed. So if you have another area of the heart that starts generating its own action potentials, then that would be considered an abnormal occurrence, because then that messes up the timing of the depolarization of the various areas of the heart. So that was not something we want. We would consider that to be an abnormal occurrence, which again is going to lead to some type of arrhythmia or dysrhythmia. These automaticity foci can occur anywhere in the atria, could be occurring in the ventricle. Again, lots of options there. And again, as we said, they normally don't generate pacemaking stimuli. They're going to be suppressed by the AV node, and then would be suppressed by suppressed by the SA node, and then suppressed by the AV node action, as the AV node is going to pass that action potential that originated in the SA node onto the ventricles. Under certain condition, though, these automaticity foci will spontaneously depolarize, generating an action potential. And again, as we said, when that happens, then that could lead to a type of arrhythmia or dysrhythmia. So when this happens, most of the time we could say that the focus has become, or the focus has become irritable. So I'm hedging on that because you can have a automaticity foci that would generate an action potential when it's not supposed to, and you would not consider it to be irritable. but many times they are irritable. So the difference between irritable and non-irritable is a function of cell biology, so I'm not wanting to get into that. First of all, it's not well understood at all, but we're just going to basically leave it as this, that many times a focus can become irritable, then it's going to start generating action potentials. But there are times when a focus can generate an action potential inappropriately and it not be irritable. Just different cell biologies are underlie that, and that's all I'm going to say about that. So when we're talking about irritable foci, what are some things that could trigger a focus to become irritable? Now, when it becomes irritable, by definition, I'm meaning that it is now going to be generating action potentials that are going to start depolarizing the muscle tissue around it, etc. And when it does, again, you've got a problem with an arrhythmia. So multiple things could affect or generate or cause a focus to become irritable. This is not an exhaustive list at all, but you could have things that you're taking in. It could be caffeine, it could be amphetamines, it could be cocaine, it could be drugs, such as drugs that work on your beta-1 receptors. It could be epinephrine. It could be, involving the sympathetic stimulation. It could be other drugs, digoxin, which we'll talk about later. Ethanol could do it. Hyperthyroidism, hypoxia could do it. Hypokalemia could do it. Stretching of the heart could cause a focus to become irritable. Myocarditis, an infection of the heart, could cause a focus to become irritable. Mitral valve prolapse, we'll talk about that later. Again, that's another way of another mechanisms for stretching the heart. Point being is there are lots and lots of things that can cause various foci in the heart to become irritable, meaning that they're going to start generating their own action potentials leading to arrhythmias. And again, we got multiple sections, multiple lectures coming on arrhythmias. So right now I'm just kind of introducing the concept to you. As I said, there are lots of areas of the heart that could possibly be generated or could become irritable or also generate their own action potential, even if it was not irritable. So we will call these latent pacemaker cells. Okay, so latent pacemakers. Okay, and latent meaning they're not doing anything. Now, if they start doing something, then they become automaticity foci and they're generating arrhythmias. So, I mean, they could be there, could be there, could be there, could be there, could be there. You got all these areas of the heart that are normally suppressed, but they could, for whatever reason, start generating their own action potentials. So here comes some more vocabulary for you. So we could say that the SA node overdrive suppresses all automaticity foci. Overdrive suppression. So overdrive suppression means that the faster pacemaking cell is suppressing all the other latent pacemaker cells, which is why they're called latent. So we're going to have to get used to that term, overdrive suppression. Okay, and so the fastest one is going to dominate, and of course, normally the fastest one is the SA node. Now, if the SA node is for some reason not functioning properly, in other words, say it stops generating an action potential, or it may generate action potentials but at an abnormally slow rate, then you open yourself up for one of these other latent pacemakers to start generating their own action potentials because they're no longer being suppressed or no longer under overdrive suppression. So when that happens, then we could call this an ectopic focus. You understand the concept of ectopic like an ectopic pregnancy. Ectopic meaning occurring at a place where it's not supposed to occur. So I have an area of the heart that's generating its own action potentials, automaticity foci, where it's not supposed to do that. So we would say it's an ectopic focus, and that it will in fact escape overdrive suppression. So when we hear the term escape rhythm, that's another cardiology term, escape rhythm, meaning it is escaping overdrive suppression and doing its own thing. So if you had a focus, an ectopic focus in the atria, and it was generating its own action potentials, we would say then, and that the atria then is beating to the rhythm of that ectopic focus, then we would say that the atria is having, we call it atrial escape rhythm. In other words, the rhythm of the atria is being generated by some focus that is other than the SA node. So atrial escape rhythm. You could have a ventricular escape rhythm as well. Okay, escape means it is no longer being suppressed. If the depolarization signal from the atria does not make it to the AV node, and the AV node is going to be at the AV junction, so there's my AV node there, AV node. Okay, right there, that's my AV node right at the bottom of that right atrium. And so, what we've said before is that the sinoatrial node or SA node will depolarize the atria, and that signal will make its way to the AV node. And the AV node's job then is to transmit that wave of depolarization through to the ventricles, but it will slow it down a little bit because, again, we want to make sure the timing is correct, so we don't want the ventricles to contract too quickly, such as trying to fight the pressure generated by the atrial contraction. So timing is everything. So the AV node is going to be communicating that action potential through it into the ventricle. So at this point, the AV node is not generating its own action potential. It is not functioning as an automaticity foci. Again, it has that ability to do that, but it isn't. All it's doing is just communicating, responding to the action potential that's coming from the atria so that it can then, in a appropriate timed fashion, communicate depolarization to the ventricles so the ventricles can contract. The AV node's normal pacing is about 40 to 60 beats per minute. So again, it is also, when things are normal, a latent pacemaker entity, and left into its own devices, that's going to be about the rhythm that it will do, which is slower than the SA node. But again, the SA node and the depolarization from the SA nodes is suppressing, overdrive suppressing the AV. But if for whatever reason the signal coming from the SA node, if it doesn't make it to the AV node, then if the AV node is no longer going to be overdrive suppressed, and then it will start its own beating pattern, and then it will generate an action potential, and it will, on its own, cause the ventricles to contract. So if you have that, then we would call this a junctional escape rhythm. Junctional meaning AV junction. So in cardiology speak, if the patient has junctional escape rhythm, what that means is that the AV node is generating its own action potentials to depolarize the ventricles, causing the ventricles to contract, and they are not in sync, they are not responding to the SA node. So in general, an escape rhythm is any rhythm other than a rhythm originated from the SA node. So a junctional escape rhythm would be just a kind of escape rhythm. One other thing that I want to mention here is that you can have an atrial escape rhythm, of course, as I mentioned earlier. Sometimes the focus, the ectopic focus of an atrial escape rhythm will be in just say one area. So let's just say we'll make it brown. Okay, I'm just picking something out. So maybe that area right there, that's the one that is generating a depolarizing event. Maybe it's irritable, and so it's doing its own thing. So it's going to be causing the atria to contract because it's going to emanate through there, and it's also going to be communicating to the AV node. But again, this is going to be an atrial escape rhythm. But sometimes what will happen is you'll have a period where an area will be functioning as a pacemaker, and then another area will generate a pacemaker, and then that area there will just kind of go away in terms of no longer generating the pacemaker, and then it will take over for a while, and then eventually then maybe it stops, and then another area will take over. So when that happens, we would call that a wandering pacemaker. And the name's pretty descriptive. It's just the entity, the part of the heart that is generating the rhythm is just kind of wandering around. So in a sense, it's tag teaming. One area of the heart will generate a rhythm, then another area of the heart will generate a rhythm, another. So it's just wandering around. So you hear that term, wandering pacemaker. Okay. So other things to be considered, an automaticity focus is overdrive suppressed if it is regularly depolarized by the pacing rate of another focus faster than its own. So I've already kind of said that. The fastest pacemaker is going to normally overdrive suppress, again, if things are going according to script. So the SA node suppresses other potential automaticity foci because the SA node is the fastest. But again, if an automaticity focus is not overdrive suppressed, regardless of the cause, it escapes to initiate its own pacemaking activity. In certain cardiopathologies, the automaticity foci are not subject to overdrive suppression, and again, we just kind of talked about that. But I'm bringing that up again because there is another term for that, and we call that an entrance block. Okay? So what is an entrance block? An entrance block is the lack of suppression of automaticity foci by the depolarization of another automaticity focus. Okay, why do cardiologists call this block? So a way you can look at this, we could say that there's something about that focus. That focus is acting out now. That focus that is not normal. There's something about that focus such that the wave front's ability to suppress the focus is being blocked. Okay, so we can cartoon it out. Say we have an SA node here. Okay, and it's going to have an action potential, and that action potential now is just going to be a wave front. A wave of depolarization is going to be emanating throughout, in this case, the atria. And so you may have some other latent pacemaker, groups of cells somewhere in the atria called the green one there. So that's going to be my latent pacemaker. I'll go LP there, latent pacemaker. Again, that wave front normally suppresses it, but there's something about these little guys right here that they are no longer being suppressed, so that there's something about the focus such that the suppressing wave is being blocked, such that now it starts generating its own action potential. So we would say then that little area there is a point of entrance block. In other words, the suppressing wavefront is being blocked such that it is no longer suppressing that area here, and now it is beginning to generate its own action potential. Lots and lots of things can cause an entrance block. Now again, just to be redundant, just to make sure we're clear, when a cardiologist talks about an entrance block, what we're talking about is a pacemaker area of the heart, a latent pacemaker area of the heart is now beginning to do its own thing. It's beginning to generate its own action potentials. We'd say that's an example of an entrance block. Loads of things can cause an entrance block. One of the common things could be you have ischemia. Maybe you have some type of issue, some coronary blood flow problems going to the heart, so it's not getting enough blood, enough oxygen, etc. So the tissue around the particular focus is being stressed, and the nature of that stressed tissue is such that when the wave front, the axial wave front comes through, because the area around the focus is maybe, again, undergoing ischemia. I got some ischemia going here. Now that wave front can't get through the ischemic part, and then all of a sudden that group of cells starts its action potentials. And the nature of the ischemia is such that the wave or the action potential coming from that group of cells that are becoming generating action potential, the wave can get through the ischemic area, but the wave from the SA node can't get to it. So, again, you got a problem. So ischemia could cause an entrance block. Infarction could cause an entrance block. So maybe instead of that area being having stress in terms of ischemia, maybe now it's being infarcted. Okay, it's dying. Same thing. The wave front of the axial potential from the SA node and the surrounding atria or atrial tissue can't penetrate it, allowing that then to create its own. It's no longer being overdriven, suppressed, so it can generate its own action potential, and there's something about the tissue that will allow that action potential being generated to go through that ischemic or that infarcted tissue and then cause a problem in terms of some type of arrhythmia. Again, not exhaustive. Again, lots and lots and lots of things can cause this to happen. So the ischemia, the infarction is just an example. Again, as I said earlier, drugs could do it, caffeine could do it, etc. So lots and lots of things can cause an entrance block. Okay? If there is an entrance block, the leading particular focus, in interest block leading the particular focus to escape. In other words, now it's going to be generating an action potential, causing tissue to contract, whether it's coming from the atria or the ventricle, one of the ventricles. That focus is said to be parasystolic. So, parasystole is a type of arrhythmia where an ectopic focus or ectopic foci are being depolarized, I said that messed up. Let me try that again. The parasystole is a type of arrhythmia where ectopic foci are depolarizing the atria or the ventricles in addition to normal beating. So this would result in an added beat. Okay, so consider this. Suppose that you had a normal sinus rhythm. Okay, so maybe you're going along at 70 beats a minute. So I'm going to scribble an ECG. It's not going to be accurate, but I'm just trying to make a point here. It comes along, you got a beat, and then another beat, and then another beat, and then another beat. Okay, so I got beat, 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 beat. And suppose this is, 70 beats per minute. So imagine now I have a ectopic focus, and it starts generating its own beat at its own time. Now, the timing may be slower than the SA node, or maybe faster than the SA node. Who knows? But what will happen is that in addition to a normal beat, all of a sudden you'd have maybe a beat there, and then a beat there, and then a beat there. So those would be your ectopic beats. Those would be an example of a parasystole. So I'm having normal sinus rhythm, normal beating, and then overlaid on that is going to be another area of the heart that is going to generate an action potential at whatever pacing it is. And so that rhythm of beat is going to be overlaid on the normal beat. And so you're going to actually see extra beats. So this would be classic parasystole. So if you hear a cardiologist saying, yeah, the patient has parasystole, what that means is that in addition to the normal sinus beating, you're going to have another focus somewhere that is also causing the heart to depolarize as well. And so those two beats would literally be overlaid each other. So you have a lot of different vocabulary that kind of means the same thing. And so what I really kind of need for you to do is to write these terms down, write the definitions out, and just kind of go over them and over them so you get comfortable with these terms, because a lot of these terms kind of overlap. Because if I'm talking about parasystole, then I'm talking about a focus that's not overdrive suppressed. Then I'm also talking about an entrance block. So they all kind of mean similar things. So I just need for you to, again, just get used to employing these terms. So one last point before we close this out. Since I've already talked about an entrance block, if there's an entrance block, you can probably guess that there's also a concept of an exit block. And I just want to toss that out here before we leave. An exit block is defined as autorhythmic cells that generate an action potential, but the action potential cannot exit that focus. So an example would be a sinoatrial exit block. Okay, so again, look at those terms and try to understand what that really means. Sinoatrial meaning SA node. So one quick point about the SA node. Of course, we saw the SA node, up here, okay, up near the vena cava. So the SA node, it's a group of heterogeneous cells. They're not all the same type of cells. Again, they have that ability to auto-generate. So you have the no resting membrane potential, all that stuff like we talked about in an earlier lecture. But generally, the SA node can be divided up into two regions. The interior region we call P cells. Okay, so I'm going to go P cells there. And then an outer region of the SA node, and those have T cells. Okay, they're just different cell biologies involved. And then, of course, out here is going to be my atrial tissue. All right? So what happens with the SA node is they're going to generate an action potential somewhere in the P cell collection, in the interior region of the SA node. And then when that action potential happens, the wave of depolarization will then go through the T cells. And then the T cells, if it allows it to go through, which it normally will then cause, of course, an action potential in the atrial part of the heart, the cardiomyocytes there. And so that's when things are working normally. What can happen is that you can have a generation of an action potential within the P cells, but there's something about the T cells that will not allow that action potential wave to make it through. Therefore, the P cells are working, but the T cells aren't letting that action potential wave front make it out. Therefore, you're not depolarizing the cardiomyocytes in the atria. So when that happens, we consider that a type of exit block, and we would consider that to be a sinoatrial exit block. Again, what that means is the P cells in the SA node are doing their thing. The problem is the surrounding T cells are not allowing that wavefront to get out of the SA node. Another kind of side point here, the area that generates a sinus rhythm, it's not all the P cells doing the same thing. You may have an area of P cells, and that be the primary generator of the action potentials, and then it might move over here, and then it might move over here, and then it might move over there. That's fairly normal. So within the P cell region, it might, it kind of goes through different places. Now, as far as looking at this from, the atrial contraction, it doesn't make any difference. you really don't have any way, unless you're undergoing experimental conditions, you have no way of knowing if the particular cells of the particular P cells, a subgroup of them, generating an action potential, then another subgroup generates an action potential. You can't tell if they're moving around or not. You can only see that in experimental conditions, but they have discovered that that's how that works. Anyway, so the exit block means, again, you have a generation of an action potential, but it can't leave the node that we're talking about. In this case, it would be the SA node, so we would say that's a sinoatrial exit block. Okay, just work on this vocabulary because we're going to be using these words over and over and over again in future lectures. And if you go into medicine, you're going to be using these words all the time when you're dealing with your patients discussing cardiology issues. Okay, see you next time.